Hi, my name is Wilson Kwong, and I'm a gastroenterologist at the University of California, San Diego. I'll be discussing our recent article, Low Rates of Malignancy and Mortality in Asymptomatic Patients with Suspected Neoplastic Pancreatic Cysts Beyond 5 Years of Surveillance. The current understanding of neoplastic pancreatic cysts is based on retrospective or observational studies, and nearly all of them have median surveillance periods shorter than 5 years. We therefore have a very limited understanding of the natural history and malignant potential of neoplastic pancreatic cysts beyond 5 years and no data beyond 10 years. The 2015 AGA guidelines recommend discontinuation of surveillance at 5 years in the absence of significant changes, despite limited supporting data. This recommendation presumes that the majority of the pancreatic cancer risk and mortality related to neoplastic pancreatic cysts occurs within the first 5 years of cyst discovery. Patients who have not developed pancreatic cancer within the first 5 years may therefore represent a lower risk population. If true, discontinuation of surveillance after 5 years would lead to significant cost reduction in the evaluation and surveillance of pancreatic cysts, especially in an older population with frequent comorbidities. The aim of the study was to determine the rate of pancreatic cancer development in neoplastic pancreatic cysts after 5 years of surveillance. This was a multi-center retrospective study from 4 medical centers, including an academic medical center, a Veterans Affairs hospital, and 2 community integrated healthcare systems. The study group included 310 patients with asymptomatic neoplastic pancreatic cysts with more than 5 years of follow-up. The median duration of follow-up was 7.3 years, with 30 patients with more than 10 years of follow-up. Patients underwent a median of 5 cross-sectional imaging studies during this time period. 3 patients, or 1%, developed pancreatic cancer after more than 5 years of surveillance, and 2 other patients developed high-grade dysplasia. A total of 212 patients had none of the 3 AGA high-risk features of mironodule, size greater than 3 centimeters, or dilated pancreatic duct. None of these 212 patients developed pancreatic cancer from their cyst. Patients with one of 3 high-risk features had a 1% rate of malignant transformation of their cysts. In patients with 2 of the 3 high-risk features, 15% developed pancreatic cancer from their cyst. 9% of patients from the study group died after a median of 76 months. The most common cause of death was cardiac complications in 4%, followed by non-pancreatic malignancies in 2%. Pancreas cancer mortality was only 1%. Mortality related to non-pancreatic causes was 8 times higher than mortality related to pancreatic cancer beyond 5 years of surveillance. Based on the present study, it appears that there's a small but persistent risk of malignant transformation beyond 5 years and even 10 years of surveillance. Because the risk of malignant transformation beyond 5 years is comparable to the 1% mortality of pancreatic resection at even high-volume centers, the argument can be made that discontinuing surveillance after 5 years is justified. No cancer is developed after 5 years in patients with pancreatic cysts lacking all 3 AGA high-risk features. This lends support to discontinue surveillance in this low-risk subgroup, especially for those with medical comorbidities. In patients with 1 AGA high-risk feature, only 1% of patients developed invasive malignancy, and therefore discontinuation can also be considered in this group. However, in the presence of 2 AGA high-risk features, the risk of long-term malignancy was 15%, and therefore surgery should be considered, especially in patients who are still surgically fit versus continued surveillance. Our study also showed that beyond 5 years, patients were 8 times more likely to have mortality from non-pancreatic causes than pancreas cancer. After 5 years without malignant transformation, a patient's pancreatic cyst may be demonstrating less biologically aggressive behavior, possibly related to histologic subtype or lack of aggressive mutations. There remain several areas of uncertainty, including the management of healthy individuals still in the 6th and 7th decades of life after 5 years of surveillance. These patients may still benefit from continued cyst surveillance, given a long life expectancy. There are no available data regarding the risk of malignancy beyond 10 and 20 years, and therefore natural history studies beyond 10 and 20 years would be helpful in guiding decisions. In the absence of data to guide management, a decision to continue surveillance beyond 5 years should be made on a case-by-case basis among healthy individuals still in the 6th and 7th decades of life. In conclusion, our findings support the discontinuation of surveillance after 5 years among neoplastic pancreatic cysts with no more than 1 high-risk feature in selected individuals, because the risk of malignancy is approximately 1%. Among patients with 2 high-risk features who remain surgically fit, discussion of surgery or surveillance beyond 5 years should be considered. Thank you for your time.